year. Um, we hope that more people will join us in a short while, but it is really a great pleasure to have all of you here, and I look forward to a very, very good and interesting talk by our good friend, Professor Axel Hofmann, who many of you know by now, probably the world leader in patient blood management. And if I say leader, I really mean leader, the person that leads on a national scale countries into establishing and implementing patient blood management. Axel is a good friend of South Africa. He's a good friend of mine and a good friend of many of the people in our group, and also some of the people that I see here in the audience. Axel is a adjunct professor. I hope I've got all the right terms here, but he's a professor at the University of Western Australia. Been very involved over the years in other universities as well, University of Zurich. He's got degrees in different fields, including economics, and he's been the lead person on the recent, well, if I say recent, the about to be released document by the World Health Organization on the global implementation of patient blood management that we're all looking forward to. And the idea was, and the hope was, that today would be the day that we would talk about that, because we thought that it would have been released already. But because it's not, I've asked Axel to give that talk to us when it happens. But in the meantime, he has specially made a new presentation for today. And Axel, I'm going to let you release the secret out of the bag. You've seen the title on the invitation about accelerators and inhibitors, but I'm not going to try and guess what it's all about. Welcome. You're not in South Africa, but thanks for always making time for us. Every time we ask, you really make a big effort, if your busy schedule allows it, to speak to us, and we really appreciate it. And even though we're few in the room, as I think you've always said, if you find one person who becomes a champion, that can change a lot. And you were the person that really changed my mind, because I heard about PBM for the very first time at a meeting. I think it was in 2015, where you were the speaker. So here we are. Over to you, Axel. Thank you so much.
Thank you, Vernon. You're really a dear friend and colleague, and I always enjoy doing stuff together. I also saw in the audience already Chris and Anthony as my other good old friends, and I greeted you personally, but just my apologies if I don't remember other names for now, but I hope you can forgive me. So here's my presentation, and the title is A Closer Look. Can you see the slides?
Yes, we can.
Okay, good. A closer look at the accelerators and inhibitors of patient blood management. And I have to start with my disclaimer. They haven't changed a lot from the last time. So governments and public institutions, professional societies and NGOs, blood services, including the South African National Blood Service and industry. Not always, but sometimes. So just a quick refresher on PBM, very quickly. Here's the global definition. I hope that most of you are familiar with it. PBM, I use the acronym rather than patient blood management, is a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. And this has been endorsed by an ever-growing number of professional societies around the world. The urgent need to implement patient blood management is what the policy brief of the WHO states as a title. And you might have seen these graphs of 2.9 billion individuals that are either micronutrient deficient or anemic or anemic. And there's another 600 million at least that is partly overlapping with that group that is suffering from chronic or acute blood loss and or bleeding disorders or coagulopathies. And WHO states that together one of the world's biggest, largely preventable, yet greatly underestimated public health and health economic burdens are presented here. So the concept of PBM basically says we've got to look at A, B, and C, these three problems being risk factors for morbidity and mortality, not only in surgery, but in many, many other patient groups. And the default treatment was transfusion for many years, but we know now that all three factors upstream are a problem for millions, hundreds of millions of patients. And because of not managing correctly upstream, we run into another problem, which is transfusion that causes additional problems. And so we can say it is the double M, still to be corrected, Vernon. The omitted incomplete etiology-specific diagnosis and treatment is the problem being up here, leading to the problem down here. And so with this graph, I think we have exposed healthcare's biggest patient safety gap. And the only way to tackle this is by reversing the perspective, by timely and effective patient blood management or managing the upstream problem. And through this, we are minimizing the downstream problem. And the way to do this is clearly patient blood management. So that was the refresher. Now, the question is, over the years, is PBM accelerated or is its implementation inhibited? And here, this paper by Rita Rubin in 2023 says it takes an average of 17 years for evidence to change practice. The burgeoning field of implementation science seeks to speed things up. So let's see where we stand with PBM. In 2007, so exactly 17 years and 2 months ago, my colleagues Dan Friedman and Shannon Farmer designed this model together. This is the original 9-field matrix at the time related to pre, intra, and post-op. And pillar 1, 2, and 3 makes the 9-field matrix with the many PBM modalities. We should never forget this is not a model for each patient. This is a model that must be tailored to the specific patient needs. And then we submitted this, we developed a concept for Western Australia in 2007 and submitted it to the State Health Executive Forum in 2008. In 2010, the model was endorsed by the WHO. In 2015, the WHO said, we want this, but we still don't see it in place. So it is a suboptimal clinical practice that we are looking at. And so in 2017, my colleagues and I presented the results of this first health system-wide program with the full implementation of PBM. This is a real-world study, really a real-world study because it included more than 600,000 patients. And we were able, as the title is, improved outcomes and reduced costs associated with a health system-wide PBM program. And this was conducted in 4 major adult tertiary care hospitals. Other hospitals, of course, were also included, but the study population was limited to the 600,000. And so what we got is transfusion data. We saw massive reduction in red cell utilization, plasma, and platelets. In fact, we were about 2/3 below the consumption per 1,000 inhabitants in the United States. We also had activity data. We managed to decrease preoperative anemia prevalence to 14%. In other words, those who were admitted to the hospital anemic were just emergency patients, whereas all the others, elective patients, were basically treated for their anemia before hospital admission. We also managed to apply a restrictive threshold. It was not a numeric threshold, it was a physiological threshold. But in retrospect, we saw it drop from 7.9 to 7.3 grams per deciliter. And another activity was single unit transfusions increased by 33%, from 33 to 64%. In other words, the multiple unit transfusions dropped. So these are interesting data, but not really the important data. The important data were the outcomes, and we had in this huge population a decrease in mortality, infection, myocardial infarction, stroke by these numbers, and we reduced hospital lengths of stay by 70,000 stay days. So these are really, because we say PBM is patient-centered and outcomes focused. So these were the data we hoped to see, and we actually saw them. But on top of this, we have economic data that showed us that we have had saved product costs by more than $18 million, and activity-based transfusion costs were dropped by at least $80 million. And then finally in 2021, so in year 15 of, no, sorry, in year 13, we had the policy brief with the call to action for all member states to make this a national policy. And then in 2022, the World Federation of Societies of Anesthesiologists endorsed what is called the Santa Cruz Declaration. It's a declaration in favor of strengthening patient blood management globally. And what you see in the background is all the member societies that signed it. And then recently, or this year, early this year, posted in January 31st, the 100th society was signing the declaration. And then in 2025, we also expect the guidance on implementing patient blood management to improve global blood health status. This document that I wanted to show you today, it's done. It's completely it's edited. The graphic design is completed, but the WHO has not yet uploaded the document, and so I'm not allowed to show it. In fact, it's embargoed. And so I hope that I can show this to you in another talk. So it's really not my fault. It's not my procrastination. It's just technical issues. One of them might be interesting for you. One reason was that at last minute they stopped the uploading because due to Donald Trump's administration having made the decision to leave the WHO, now everyone who is on that paper who has a US affiliation or US nationality has to explicitly explain whether he or she wants to be posted or stay on the document or not. So we had to have formal approval of everyone. Of course, everyone wanted to stay on it, but these were one of these bureaucratic hurdles we had to go through besides others. Anyway, coming back to this document that is hopefully out very soon. This is already from the little thing that I can show you officially. This document has been developed to guide health authorities in implementing PBM as a national standard of care. The aim is to improve the blood health status of the population in general, as well as to improve patient outcomes, safety, and quality of care while reducing the overall cost of healthcare. This guidance also addresses the specific roles of single healthcare organizations in conducting pilot projects as models for national PBM implementation and to serve as national PBM reference centers. So now the question, where does the global penetration of PBM stands after 17 years? Coming back to Rubin's article. Well, here's a graph that looked at the penetration in 2008. There were a few single institutional programs in the United States, in Canada, in Austria, in Switzerland, in Australia. That was the situation 17 years and 2 months ago. Now we have this situation. We have many countries that have at least multiple institutional programs, or have these programs plus guidelines, or have this plus health authority support, or even have national pilots or demonstrational projects under the auspices of the federal bodies, federal administration or jurisdictional administration. I have put South Africa into the group number, the second best health authority support. Vernon told me earlier on that the support is not yet formal, but de facto there is the support, and so I'm very happy to have you here in darker green. So now the question, what are the accelerators and inhibitors of PBM? You might have seen this paper, Making PBM the New Normal, as experienced by implementers in diverse countries. And they showed as drivers, this was based on in-depth interviews across experts and PBM KOLs and champions in these countries. And they said, well, the number one driver is clearly patient outcomes, followed by cost savings, but also the prevention of blood shortages, because we reduce the demand for the product, patient safety, and other factors. Now, when we did the accelerators, inhibitors face-to-face, they all felt that the number one accelerator would be to show or to generate and then publish local PBM data, followed by education and training and national policy, strong PBM thought leadership, and other factors. And the inhibiting one was low awareness, no funding for setup, education gaps, stickiness of old practice, lack of interdisciplinary commitment, and again, other factors. There's a strong relationship between these two leading things. There is data out there, but the data is not known. The awareness is still low. And I personally think that I understand that those that have been interviewed feel that we need local data. However, if you ask someone, do we need data for the efficacy of sepsis management, or for antibiosis, or for hand washing, you would say no, of course not. This should be standard of care. It's proven, and I think with the amount of data we are having meanwhile on PBM, there is no need to prove that PBM is working, functioning. What you probably need is local data about PBM activities, but I don't think too much. I mean, the focus, and it's nice if you report improved outcomes, but I think we have passed that moment. Anyway, the big question that was raised in 2022 is, after we know that it improves outcomes for millions while saving billions, and I'll come back to that in a moment, what is holding it up? And on top of what you've seen before, we have created in that document, in that paper, this graph of a few key factor groups But the biggest we felt is cultural behavior in inertia. And this has very little to do with data and with studies and with evidence. This is really something in the realm of psychology and behavioral sciences. And I just want to show you how deeply rooted the behavior and this whole mindset is. This is a paper by Roberts in Lancet Hematology 2019. The global need for blood products, including platelets, plasma, red cells, and cryo, was estimated to be more than 300 million units per year. And I'm worried about this term, the global blood need, because whose need is it? Is it the patient's need, or is it the physician's demand? And if we look at this graph where they break the, in fact, here they use the word demand. They break it down by regional demand per 100,000 population and the different causes. And then I asked the question, why pushing the global supply above 300 million blood components rather than reducing the demand by 50% or 150 million components with equal or improved outcomes? Because this is exactly what PBM can do for the system. In other words, why not exchanging the product focus against the patient focus? And even more so by knowing that we live in a hyper-aging world society. This is the population pyramid in 2017, from the newborn up to the 95 years of age and older. That is 2017. But in 83 years from now, this is the form. This is changing from a pyramid to a sarcophagus shape. And what is really worrying is that the number of individuals 80 years or older are projected to increase from 140 million to almost 900 million. And how on earth could we resolve this problem of A, B, and C, anemia, bloodless coagulopathy, with the use of blood products, which is not indicated anyway in most of the cases? But this is still on the mind of many. And I just want to show you more about this behavior and mindset with this interesting paper by Carson and colleagues in 2017 in the New England Journal of Medicine. They state red cell transfusion over time have fallen from 50 units per thousand in 2008 to approximately 40 per thousand in 2013. The increasing adoption of patient-focused blood management programs in hospital worldwide accounts for most of these decreases. Then they continue with rates of red cell transfusion in the US are still among the highest in developed countries, suggesting that patient-focused blood management programs have additional capacity to reduce unnecessary blood transfusions. However, US medical practice with major programs for trauma resuscitation and aggressive programs of solid organs and stem cell transplantation may explain the persistently high rates of RBC transfusion in the US. So there's a few interesting observations. Number one, they don't use the term patient blood management. They say blood management programs, they say patient-focused blood management. And we have learned, all my colleagues, and I think including you, Vernon, whenever we try to publish in the leading journals like Lancet, New England Journal, there is this reluctance to use PBM as a term. It doesn't resonate well with within the cathedral of medicine, and we are still felt as the heretics in the system. Anyway, it's also interesting that there's still the product focus. They think it's about reducing unnecessary transfusion. That they still didn't get the concept of, well, we are going to treat anemia, bloodless, and coagulopathy, regardless whether this patient will or will not be in a situation where a transfusion might be indicated. And then they come up with this argument, trauma and transplantation, solid and stem cell is really where we have the limitations. Now, I think this is a nice opportunity to look at exactly these two areas and see whether we are still battling even their behavior and psychology. Cultural behavior in inertia versus PBM in the trauma setting. Here's a statement from Dr. Eric Gary. What does emergency blood shortage mean? And he says down here, blood shortages leave doctors with no acceptable options. Only solution is more blood donors. Okay, this is the executive medical director of one of the largest blood services in the world. And then in that article that is linked to this statement here, it says on the trauma, one of the most important advances in trauma medicine is the recognition that providing blood early can help save lives by preventing the development of intractable bleeding or bleeding that is difficult to stop, the coagulopathy of trauma. And I don't want to go further, but I want to add another one. Saying blood transfusions at the scene saves life, but ambulances are rarely equipped to do them. And it says in that one, more than 60,000 people in the US bleed to death every year from traumatic events like car crashes or gunshot wounds or other emergencies, including those related to pregnancy or gastrointestinal hemorrhaging. It's the leading cause of preventable death after a traumatic event. And then also at a news conference last fall, members of the American College of Surgeons estimated that 10,000 lives could be saved annually if more patients received blood before they arrived at the hospital. Is this a correct assessment? Well, interestingly, the European Guideline on Management of Major Bleeding and Coagulopathy Following Trauma, it's the 6th edition, is very well known. It's quoted almost 3,400 times and is accessed via the journal website over 1 million times. And you might be familiar with these very comprehensive guidelines. And what you see, it has major partitions, Roman 1, initial resuscitation and prevention of further bleeding, diagnosis and monitoring of bleeding, tissue oxygenation, volume, fluids, temperature, rapid control of bleeding, initial management of bleeding, coagulopathy, further goal-directed coagulation management, management of antithrombotic agents, thromboprophylaxis, guideline implementation, quality control. And the only mentioning on that initial page of transfusion is up here, pre-hospital blood product use. And then they say there is no recommendation at this time. So this is in contrary of the advertising PR style information that we saw earlier. And why is there no recommendation? Well, the best evidence available to date for pre-hospital plasma administration is derived from two pragmatic RCTs, the PAMPER study and the COMBAT study, which have yielded conflicting results. A meta-analysis of both trials, including 626 patients, showed reduced 24-hour mortality with pre-hospital plasma, but no effect on 1 month mortality. Further on, the multi-center phase 3 RCT REPHIL, resuscitation with pre-hospital blood products, trial compared pre-hospital 2 units of packed RBCs and lyoplasts each, or up to 1 liter of 0.9% sodium chloride in adult trauma patients with hemorrhagic shock and hypertension, and did not show a difference for the composite endpoint mortality and or lactate clearance. The trial was stopped at 432 out of 490 patients due to SARS-CoV pandemic. So in other words, what the experts are really telling is basically apply the 3 pillars of PBM, and I grayed out the first pillar because these guidelines in the acute care setting, in the acute bleeding situation, are focusing on pillar 2 and pillar 3. Now, here's the other scenario: cultural behavior and inertia versus PBM in transplant settings. Do you remember I started with Carson's statement on, well, there's the limitations, trauma, and transplant is where we still need the blood so much. Number one, if we do a solid organ transplant, it's true that at least in the past, this went along with multiple liquid organ transplants. In other words, if you want to perform a solid organ transplant, then you usually consume large amounts of red cells, platelets, and plasma. This is the behavior, this is the culture that we are familiar with. However, already in 1999, there's this paper in Anesthesiology, Total Blood Transfusion and Mortality After Orthotopic Liver Transplant. You see from 0 to more than 80 units, and you see the 72 hours post-op mortality in these patients that were massively transfused. This is now data 21 years later from Korea, South Korea, of course, with about 1,100 and 1,600 naive liver or kidney transplantation recipients over 10 years. And 94% of the liver recipients and 59 of the kidney recipients received transfusions related to the transplantation operation, mostly platelets and FFP. Higher mortality was observed in those receiving transfusion than that in patients without. And you can see here the different products over the years from 2008 to 17. Red for red cells, blue for FFP, green for platelets, and black for cryo. And you see that they're all somewhere, you know, the red cells somewhere between 5 and 5.5 units, platelets between 4.5 and 7 units. And this is for deceased liver donors, donor recipients, and here for the living liver donor recipients. What you also see, mortality, all here the significance value, significance level. Liver recipients not transfused versus transfused, 16 versus 20% mortality. Then for living donor transplants, there was almost none not transfused in the living donor transplants, and the mortality in the remainder is about 29%. And then in kidneys, we see 3.2 mortality in the non-transfused and 6.5 in the transfused. Here's an interesting paper that compares blood banking and solid organ transplantation across centers and over the years. And you see there are some centers like Pittsburgh with a average use of 36 units, plasma 36 and platelets 5. And there are other centers, and I want to, this is Nick Jabour's work, I think, in Los Angeles, with a small group. This is Jehovah's Witness population with 000 for all the products. So you see quite a wide variation. But the big question is, could we apply really successfully, and in contradiction to the statement seen earlier in the New England Journal, if we do PBM in transplant surgery? And Angel Perez Calatayud, one of our big champions of PBM, published this recently, PBM and Liver Transplant, a concise review. It is a 9-field matrix specifically designed for transplant surgery. This is his team. This is the PBM task force in the hospital, in the General Hospital of Mexico City. The model is really comprehensive. A health problem occurs, and there's a complete diagnosis, including the etiology of anemia and coagulopathies in all the surgical patients. There's a prehabilitation program where possible. There is perioperative care coordination and individualized therapy. There's a follow-up, including post-intervention anemia management, and that leads to improved health status. So we call this the multidisciplinary PBM continuum of care that is also applied in orthotopic liver transplant. And here are the results from the first 45 consecutive liver transplant. This is unselected, consecutive. And these are the raw data. And I'm allowed to show this because Angel and I showed this already at the Transplant Congress in Mexico end of last year. And we are now working on the publication. I will not show you the control group, but I will show the results from that program. So the mean amount of RBCs transfused on these 45 was 0.17 red cells. We used a total of 8 red cells in 6 patients. There was no use of FFP. There was no use of platelets. There was an in-hospital mortality of 0, and there was a 12-month mortality of 4.4%. These are unheard results so far. And again, this is consecutive. So when you see this, then you might ask, in view of all these data, are there possibly other factors inhibiting the uptake of PBM, factors that we have not considered? And if you look at this model here from this Millions Billions paper, PBM is good clinical practice with the preemption, diagnosis, therapy, and follow-up. We have tremendous evidence, compelling evidence that stakeholders are alerted to act. We have strong economic data that shows that stakeholders are enabled to act because PBM brings money back rather than consuming money. So what is remaining is the ethical aspect. Stakeholders are obliged to act. And there might be a problem on the ethical level. And I come to another paper published in the New England Journal of Medicine on the sounding board. This is by Harvey Klein and Jay Epstein, Chris Ruda, all very famous individuals in the transfusion world. And they say the decline of transfusion is largely a result of both advances in medical practice that benefit patients and hospital cost containment efforts. So that is a very nice and correct statement, right? It is improving outcomes while it reduces costs. And now is the worrisome aspect in that article. However, it says, one consequence of declining blood use that was not widely anticipated is the loss of the major source of revenue for blood providers, which has resulted in financial uncertainty and economic instability. And I'm personally irritated with that statement. That belongs probably to the Harvard Business Review, but I think it's misplaced here. It's a dilemma. And if you look at that more recent publication here in American Journal of Hematology, United States blood pricing, a cross-sectional analysis of charges and reimbursement at 200 US hospitals. That's a very busy chart, and I don't want you to read through it except for this here. The charge to the system in the US for one RBC transfusion is $2,388 US dollars. And now it says here, based on the 2019 National Blood Collection Utilization Survey, which describes 11 million annual RBC transfusions in the US, the estimated total charges would equate to $26 billion for red cell transfusions alone. And you might have heard that this earlier statement improving the outcomes for millions while saving billions. Some people felt this is a bit overstretched. Not at all. We are talking globally of hundreds of billions of dollars that potentially could be saved. And here is the most recent regulation of the European Union that came out late 2024. And regulation means that what is written in this document must become part of the legal a body of legislation of all EU member states. And SOHO stands for substance of human origin. This includes also donor blood. And this Article 12 says SOHO entities shall not, and this is the blood banks included, apply SOHO preparations to SOHO recipients without proven benefit. SOHO entities shall not apply SOHO preparations to SOHO recipients unnecessarily. SOHO entities shall make optimal use of SOHO, taking into account therapeutic alternatives and following the most up-to-date guidelines. And then finally, SOHO entities shall not advertise or promote particularly SOHO to potential SOHO recipients or to any persons granting consent on their behalf or to a healthcare professional using information that is misleading, in particular as to the potential use and benefits to SOHO recipients or minimizing the associated risk of the SOHO concerned. They also should not apply allogenic SOHO for purposes other than the prevention or treatment of a medical condition. And that reminds me of what Arya always says, transfusion therapy, but what is the disease? And in many, many cases, it is given without a proper diagnosis. And things like this, statements like this, saving 3 lives with 1 pint of blood. We all know that this is not true. We know that it has a life-saving potential, but these are misleading statements, or even this one, your blood can save 4 lives. In contrary, here is a model that is, I call a model of excellency, and this is Sanbus and Western Cape Blood Services. The use of blood and blood products in South Africa, they start with a introduction that starts with the word or the term patient blood management. The first chapter is dedicated to PBM. It gives the background. It explains in a very sober, elegant, beautiful way what PBM is and what's not. It's focusing on anemia. It's mitigating transfusion risk. It's improving outcomes. It is a cost-effective healthcare. It shows the 3 pillars, the 3 phases. It goes into more detail, and it shows also that it's a multidisciplinary approach and who is responsible for what. And finally, a large body of additional literature. And then they come into the actual blood transfusion and its legal aspects. And again, very laudable. They look at the informed consent, and patient empowerment and informed consent is so elementary to what the WHO wants healthcare systems to focus on worldwide. So in summary, what are the accelerators and inhibitors of PBM? Is it things or is it people? And we looked at things, we looked at concepts, right? Then we looked at behavior. But finally, what we have probably overlooked is the real accelerators, but also to a degree the inhibitors are people. And here in this document, we saw in the bottom up that individual leadership, championship, clinical department champions, individual initiatives, and so on and so on, is always the people. My very humble friend, Angel in Mexico, he's just said coordinated bottom up, but Mexico is driving this program again with a large group of champions very successfully. And the PBM initiation years ago started with individuals. They all worked in isolation and finally found each other. Now we have this level of penetration, and we have a lot of champions around the globe. And if you look at that map here, and we read at the end, clinical champions are individuals who are dedicated to support, advocating for, and spearheading an implementation initiative, and who overcome resistance that may occur at the organizational level. They have an intrinsic interest to implement change and to use their position to motivate others. Their strong communication and mentorship skills include collaborating with others, advocating for change, the ability to negotiate, as well as educate and facilitate learning. Strong communication and mentorship skills can facilitate buy-in by conveying the conviction and positive perception about the initiative to their peers. Champions can also effectively tailor messages to different audiences to maximize engagement and buy-in. These attitudes and capabilities could also apply to non-clinical professionals such as public health representatives, hospital administrators, and other healthcare-related professionals. And I can only congratulate you on what you're doing in South Africa, Anthony, Chris, Vernon, Karen, so many others. And it is to you that I want this guidance document to be dedicated. So thank you for your attention.
Axel, thank you so much. That was a wonderful, full, different type of perspective and really useful also, I think, for us to take forward in our different communities and hospitals. Can also say we've got a couple of other champions in the audience, people who have done amazing things. I see Wayne Simmons, who was the main author on our guidelines in gastroenterology that you know of. Yaglan Naidu, who won the KZN, if I remember correctly, the Premier's Prize for great efforts and huge cost savings in Pietermaritzburg in KwaZulu-Natal. So it's really fantastic to see how different people have come together to make change. And I also want to again highlight the role of the blood services. And I do have to say they have played an enormous role. They've really put it into practice. The blood service, or the South African National Blood Service, for example, has got full-time staff helping with patient blood management. Petrolise, that you know, is doing a huge job in education, telling everybody about PBM and also the legal aspects. So we are very fortunate in South Africa to have an incredible group of people, but I think many people are still faced with challenges in local implementation. I think many feel isolated and don't necessarily have the group around them that drives it with them. I think many of us are scattered all over the country, but the momentum is growing and the group is becoming stronger. So we are happy about that.
Again, congratulations, because I mean, as you said, we met in 2015, so 10 years ago. You have 17 years, as you saw in the presentation, but you're already there after 10 years. What you are doing in your country and with the relative resource constraints, I'm deeply impressed. And at the beginning of my presentation, there were not that many, and so I can see no other names that I'm familiar with. So I greet you again, everyone, and I also want to thank you for your outstanding engagement, and that we can show to so many other parts in the world what can be done with the right attitude. And this comes back to my advocacy for championship.
No, absolutely. And on that note, I want to open the floor to anybody who would like to make a comment. I see Sharoch Narwar. Sharoch is a hematologist, Axel.
We met.
As you know,
I met Sharoch. Hi, Sharoch.
Yes, and he's very passionate about iron and iron treatment and a regular attendee at many of our meetings. He says he's extremely frustrated that he sees so many patients who donate liters of blood and not given ferrous sulfate, then told they can't donate anymore because they are iron deficient. Yeah, it's a challenge we're trying to overcome with the donor iron replacement program that's now become or supposed to be routine, but there are still some gaps in the system, as Shirach is pointing out. But I think it's been a huge move forward that the blood services are now actually testing their donors, not just with a finger prick and a drop of blood going into a solution, but actually testing their ferritins and providing feedback on their ferritins and also giving them iron supplementation, which is really great. Any other questions or comments from the floor? So maybe I could just add something else that's not in press yet, but she's not in the audience right now, but Vanita Rumberich, who works for the South African National Blood Service, will probably hand in her PhD in the next week, which is focused on developing a framework for patient blood management implementation in South Africa. And I just completed reviewing the 8th and last chapter last week. So she's busy crossing the T's and dotting the last I's before uploading it to the university system for examination. But that's going to be very exciting when it comes out. I can now speak from having seen it already. There's some good stuff coming out, and I can also just mention that we've got at least 10 master's students working on different, and we've also got some PhD students working on different aspects of PBM now, that in the next year or two, we'll see more coming out and more presentations. That's at least from our group, and I know many other groups are busy with the same around the country. I'm going to ask Jagelin. Jagelin, I'm going to put you on the spot here. Do you want to just in a nutshell share with us some of your experiences relating to accelerators, inhibitors linked to today's talk? How did you experience that in Pietermaritzburg, and how were you able to overcome them? I hope Jagelin is still there.
I hope he didn't overcome the accelerators.
Okay, he might be on a call. He's a very busy man as well. So, okay, I see there's another question in the chat. Right, so Dennis Allard works in Rondebosch Medical Center. He works in trauma. We actually saw each other earlier today. He is from Luxembourg originally. He says, from a trauma perspective, treatment of a bleeder is stopping the bleeding, and that needs the right patient to the right place in the right time. But few bleeders are coming to the hospitals with trauma surgeons available, and that needs system improvement.
I mean, you saw my citation of the trauma guidelines, European trauma guidelines. I think it's 41 or 39 recommendations, it's Rosson and Donat as the first author, and Donat Spahn is the last author, and we know they are also, I mean, PBM pioneers from the very early beginnings. And when you look at the programs, for instance, in Zurich, the University Hospital in Zurich, where they implemented a fully fledged PBM approach for trauma patients, trauma victims, their utilization of blood products went down significantly. And at the same time, they improved the ICU mortality, hospital lengths of stay significantly. So they were showing if this is a collaborative effort of the entire department, and as I think Dennis says at the end, it needs system improvement. They improved the system. They thought the concept, they thought the continuum of care, thought it through from the scoop and run to the follow-up post-discharge, and it works.
Totally. Christian Tuten from Cameroon. Nice to see you again, Christian. He's also a regular attendee. He says, excellent. Thank you from Douala, Cameroon. Nice to have you here. Can I ask maybe Anthony Beaton? Anthony was a champion of PBM before I even knew about the concept, and works in private practice and has done lots of fantastic work as a champion in South Africa and in his region. Anthony, do you want to maybe provide some commentary?
So I love this talk, Axel, because around every corner you find a potential accelerator and inhibitor. In fact, I'm dealing with one at the moment in the transplant environment, in the solid organ transplant environment, where the point of care monitors have been moved off-site. So I guess we can't really call them point of care monitors, and it's been done for reasons of security and financial reasons for the laboratories. But in fact, I just put a comment in the chat that trying to deal with major bleeding situations with gut feel and kind of thumbsuck approach is a guarantee of transfusing more than you ever transfused in your life before, because inevitably you create a coagulopathy by transfusing individual components. So the availability of real point of care monitoring made a huge difference when we had it. We've actually taken a retrogressive step. I'm hoping that will be quickly sorted out.
Yeah, you see, this brings me back to the ammunition that we use now worldwide, even in extremely resource-constrained areas. And by the way, this will be addressed also in the new guidance document. But the ammunition is the 3E. It is the evidence, it's the economics, and therefore the ethical obligation. And wherever you can, especially of course, with the administrators, when they say for economic reasons, for financial reasons, they take out the point of care correlation management equipment, then they are wrong. They are absolutely wrong, because the economic evidence on the return of investment of point of care correlation management, for instance, with the work of Bronwyn Pierce in Brisbane, in the Women's and Children's Hospital, and also in a large heart center in Queensland, showed that with point of care testing, they added for 1,100, they compared two times 1,100 cardiac surgery patients, right? The pre-point of care testing period versus the post-implementation. So in the post-implementation, they spend about $44,000 more on point of care test assays, right? But they reduced blood utilization by more than 1 million. Plus, they reduced the average length of stay. Don't nail me on that, but I think around 15%. So there was an immediate return and a multifold return on investment. And so if you want me to talk to your C-suite or to your chief administrators, I'm more than happy to support you, Anthony.
Thanks, Axel. That's very useful. Dennis Allard makes a good point here. The massive transfusion in trauma patients is almost exclusively seen in penetrating trauma, which is, of course, very common in our part of the world. And those patients need damage control surgery ASAP by someone able to stop the bleeding by all damage control means. Then TEG-based resuscitation. The longer it takes to stop the bleeding, the poorer the outcome. And I think I'm so glad, Dennis, that you are pointing this out, because, I'm very biased towards anemia and iron deficiency, and I talk a lot about this, but stopping the bleeding is a key part of the patient blood management approach. And we shouldn't forget not just the tools, but the actual surgeon and the surgical expertise as part of our programs to manage this. And I think we're fortunate in South Africa, although we don't have enough people, we have lots of surgeons that are very experienced. Unfortunately, they are not necessarily in all the places where many of these patients are seen. So yeah, thank you also for your contribution to South African health, and for coming here and for doing your part. It's really fantastic.
Thank you, Dennis. I can only echo what Vernon just said. And of course, again, in the European trauma guidelines, there's a strong emphasis on damage control surgery. And Arya Shander says, PBM and trauma, stop the bleeding, and stop the bleeding, right? And another statement is transfusion doesn't close holes. And I think we must make particularly surgeons aware of the fact that blood is an organ, and they cannot afford to waste that organ. When they fix, for instance, the heart, the pump, right? They must be aware that they cannot do this on the expense of another organ, which is the blood. And ironically, the blood is exactly that organ that should be pumped through the heart, right? So it is the mechanic that drives the fluid. So when I said this to a cardiac surgeon in the US, I said, you're doing a poor job when you waste the liquid organ in favor of an operation on the solid organ. He said, wow, I've never looked at it from that perspective. And that made a change.
And I always like to remind people that decades after a red cell transfusion, you can often find the evidence of that original transfusion back as microchimerism, which means that some of the cells that were transfused have embedded themselves permanently into your system. Not to speak of the sensitization that we often have to struggle with in hematology from patients who have previously been exposed to blood transfusions and develop antibodies and have difficulty later on, which I don't think is seen in many other places, but in hematology, it's really, especially with platelets, a major problem that is very difficult to manage.
And I think we should start with an award. We should create an IFPBM award and give it to those surgeons who really prove to be factor 14 surgeons. The ones that really stop the bleeding.
They should have been given factor number A1.
Yeah.
Unfortunately, our time is up, so it's time for me to close. I failed to remind everybody that this ECHO meeting is hosted by the Gastro Foundation, for which we are extremely thankful, in association with Project ECHO of the University of New Mexico. Sessions are held on every Wednesday, the same time, this time of the afternoon. And we have in the background, you may not know it, but there's a background team in University of New Mexico and India that supports this technically. Everything, all the talks we host are actually recorded and will be on the Gastro Foundation website to look at again. So thank you for that, Gastro Foundation. Special thank you to Cheryl Valentine and Karen Fenton, who's part of the prep team. And also remind you that next week's topic will not be PBM, but lower endoscopy, because this is actually a gastro site that we are fortunate to share in. But I deliberately keep this to the end, just to say, Axel, thank you. There's so many things that we can thank you for, apart from this talk today, which of course was magnificent, but the role you've played, the mentorship role you continue to play, the very hard work. I know you've been through incredibly difficult times writing this WHO thing day and night, and all the other issues around you with family illness and things. It's just fantastic how you keep going and motivate all of us and encourage us. So thank you for that, and we wish you well. And we're going to celebrate in South Africa when that thing comes out. So by the way, everyone, Axel is on our patient blood management WhatsApp group in the background often, but he's there. And
Yes.
we really, really appreciate your support.
Thank you
So
so
with
much.
that,
Thank you for the nice words, and it was my pleasure to be with you again today.
fantastic. And all the best to everyone. Have a wonderful evening. Thanks, Anthony, as well.
Thank
And
you.
thank you, everybody, for coming and supporting this meeting. Bye-bye.
Bye-bye.